Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gaulin.
Hey everyone, welcome back to the Gastro Girl podcast. I'm Jacqueline Gaulin. You know, many people live with symptoms like trouble swallowing, food getting stuck, or unexplained chest discomfort without realizing that these may signal chronic inflammation in the esophagus. Today, I'm joined by Dr. Neil Parikh, a leading gastroenterologist and innovator in digestive health. Dr. Parikh serves as Chief Innovation Officer at Connecticut GI. He's Chair of Innovation for GI Alliance and Chief of Gastroenterology at Hartford Hospital. He's also an assistant clinical professor at UConn and host of the Gut Doctor podcast, where he shares practical insights to help patients and providers navigate digestive health with clarity and confidence. Welcome, Dr. Parikh. This is so great to have you on the show today.
Thank you, Jackie. Thank you for having me. Please call me Neil.
Oh, it's so hard to call doctors by their first name, but I'll try.
It's so much easier.
Anyway, let's jump right in. We've done a bunch of different podcasts involving EoE, and we never can say enough about the symptoms because there are so many people that have been living with these symptoms for years and years. Why is it often difficult to recognize?
Yeah, no, great question, Jackie. So EoE is an inflammatory condition. I call it almost an allergic inflammatory condition, right? Something triggers an allergic cascade, which leads to inflammation. And EoE is a chronic disease. So over time, you have recurrent inflammation, specifically EoE, meaning eosinophilic esophagitis, or inflammation of the esophagus. You have chronic disease, chronic inflammation all in the esophagus. Part of the reason there may be a delay in why we are still needing more of these kinds of episodes to raise awareness is that it's a pretty new diagnosis. It is a condition that did not exist, or it did exist, but wasn't labeled as such when I was in medical school or residency.
Oh, wow. So what are some of the most common symptoms that I won't even say patients because they may not even be under the care of a healthcare provider, but what are the most common symptoms that people are experiencing?
Yeah, so what we always talk about is difficulty swallowing. And I love how you mentioned not necessarily patients, because you may be at a restaurant and you're going to see your loved one or your friend, and you're going to start like, hey, are they having a little bit difficulty? Are they drinking more water? Are they clearing their throat more? So that it can be as subtle as that, to obviously food getting stuck and requiring a Heimlich maneuver, or there's more atypical symptoms, chest discomfort. You may feel like you have persistent reflux, but it's not clearing with all the medications you're trying, and you keep needing to drink fluids. And I always hear the story. Oh well, I felt like something got stuck, but then it was okay. I drank my entire glass of water and then I was okay. Well, that's not probably okay.
Let's stay with that a little longer. It's not okay. People adapt. We just did this amazing episode with a patient named Samantha, and she talked about how she was adapting and with all these different tricks that she did for years since she was a child and living with it. And it's like normal to chop your food and take so much time eating, gulping water. And that's not normal. People shouldn't have to live like that, right?
No, it's not normal, but we evolve, we adapt. We realize, all right, when I take that piece of food and I eat it that quickly, something doesn't feel right. So rather than going and raising alarms saying this is wrong, we're all busy, right?
Right.
And we're like, okay, well, if I can just adapt or evolve or fix it, I'll do that. It also tends to affect people, a demographic that is not very much in tune with their healthcare, right? The textbook patient for EoE is your young male, anywhere from 18 to 25. That population is going to likely suck it up and move on and just keep eating or drinking more water to get that food down, rather than saying, okay, well, I got to figure this out. Something's wrong.
Do you have any patient anecdotes that you could share with us about a young man who maybe was dealing with this, thought it was okay? I mean, just put it into perspective for us.
Oh, so many. The classic stories, you see them. I was on call Christmas this past year. It's a holiday. They're visiting their family in town, and they have the food impaction. You've removed the impaction, and then you talk to so and so, and then they tell you, well, yeah, every so often something gets stuck, but then it goes away. I'm okay. You almost always hear that retrospective story where when you really pick at it, they tell you, well, this has happened quite a few times. And then you have the other side where you have patients who've gone to healthcare and say, hey, this is happening. It's weird. It feels like there's pressure there. And sometimes we're a little concerned about our younger people undergoing endoscopy, right? May not want a 12-year-old, 13-year-old undergoing endoscopy. And so you then have that other perspective where they've been trying to seek care, but for valid reasons, we try not to be super invasive, and that also delays the diagnosis.
So, are symptoms different in adults versus children? And if they are, can you explain what the differences are?
Sure. And full disclaimer, I'm not a
Right.
pediatric gastroenterologist, so I will tell you my take and when I speak with my pediatric colleagues. For younger kids, the symptoms really end up being a modified failure to thrive, right? You can really you're not on your curve anymore. You're not just a picky eater, but you're vomiting when you eat anything. You really slow down how much you take in, or you just don't take in enough, right? And then you have the rest of the category, the teens, the adults, which is more the classic trouble swallowing, food impactions, or just avoiding large categories of food.
Yeah, and for adults, we can just rehash what they are, just not chopping up the food a lot and just things getting stuck, right?
Yeah, I mean, trouble swallowing is one of our alarm features in adult gastroenterology, right? So when someone says trouble swallowing to us, we ask, and I always ask, what are you having trouble swallowing with? Is it liquids? Is it pills? Is it solid food? And based on that, we triage where the patient fits and what we need to do next.
Okay.
So we almost always in an adult population will jump to an upper endoscopy.
Right. So, what are the key flags that should prompt someone to go and seek care from either their primary care if they need a referral or directly to a gastroenterologist?
Yeah, I believe dysphagia or trouble swallowing or food impaction is an automatic visit with the gastroenterology provider. Automatic. Oftentimes it happens because you have no choice because you're in the emergency room. And now you're gonna have that visit with your gastroenterologist at 1 in the morning. But ideally, anytime you mention trouble swallowing or you feel trouble swallowing, you seek care. Beyond that, I have had examples of the atypical chest pain. Those patients typically have undergone cardiac evaluation, heartburn evaluation, acid suppression, and then they get diagnosed with eosinophilic esophagitis.
So that's a lot of evaluation before a final diagnosis. Isn't it upwards of like 10 years before someone's finally diagnosed? Have you heard that statistic?
I I have definitely been told it takes a while, and I think goes back to what we were speaking about a few minutes ago, where some of our younger patients, our younger loved ones, the signs are a little more subtle,
Mhm.
right? They're 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 not they're not great eaters, or they vomit easily, or they are food aversions. And then they're young, so we don't want to just go to upper endoscopy, which is what you need. So there is that delay. So I'm not surprised. I think we're getting much better in the adult population, where you mentioned trouble swallowing, or if you ever have a food impaction, you get diagnosed much faster.
Yeah, no, and I've often read too about the link between, like you said, it's an inflammatory, type 2 inflammation. Is there a connection even with, say, immune issues, like if there's something with asthma or allergies? Is there any connection that people could maybe think about with EoE possibly being presented?
100% Jackie. We call it the allergic triad, is what I call it. So in my smart phrase for EoE, it automatically will ask, do you have asthma or eczema? Do you have as a child? Do you have any other autoimmune conditions? Because like we started the conversation, it is, as far as I'm concerned, an allergic response. Then triggers this chronic inflammatory cascade. And a lot of those patients tend to also have reactive airway disease like asthma and autoimmune or allergic skin manifestations like eczema.
No, thank you for clarifying that because I think, the more patients understand the connections between something they may already have as a diagnosis, and maybe this uh, could open their eyes and have a very meaningful discussion with their healthcare provider if they are experiencing any of the symptoms that you described. So, why do you think patients go undiagnosed for so long?
I mean, I think the primary reason is it's twofold, right? One, as a patient, I learned to evolve and adapt, right? I'm 19 years old. I'm in college. I have a lot going on. I'm trying to figure out what I'm going to do the rest of my life. Yeah, food feels a little sticky when I go out to that one steak restaurant that I really like. But you know what? I'm going to eat a little bit less of that, or I'm going to chew very carefully, or I'm going to have a larger glass of water with it. So I evolve. Okay, that's one. Secondly, like we mentioned, there is a delay on the healthcare system side, especially in our younger patients, because we are reluctant to jump to that conclusion because the symptoms are subtle and the testing is invasive. So that combination makes it challenging. And I think those two really are currently the issues. Traditionally, and I would say traditionally being like 10 years ago, we didn't have the awareness. That awareness piece, I really think, again, thanks to people like you and this kind of episode, is really changing.
So, thank you. So, one of the things I wanted to really highlight here is what happens. Like EoE is, you can't cure EoE, correct? It's a chronic condition. And the reason why I want to bring some light to this is what happens if EoE continues to go undiagnosed. It's a progressive disease. So give us a sense of what is happening in the esophagus and why it's so important to get evaluated sooner rather than later.
Yeah. So we have an allergen, right? It triggers an inflammatory response. If you keep having inflammation, eventually inflammation means recruitment of different types of cells in your body to that one specific area. So if you're persistently inflamed in one part of your esophagus, for example, and I'm really making this, for my sake, as simple as I can, you keep bringing these cells there, you keep bringing these cells there, you now have a collection of cells there. That results in scarring. All right. Persistent inflammatory cascade, scarring. Scarring in your esophagus will eventually stiffen your esophagus or narrow your esophagus, leading to a stricture, which is a physical narrowing at the end of your esophagus. I often tell patients, whether it comes to different esophageal diseases, such as even Barrett's, if you keep scratching your hand or your palm, eventually you get a scab there, right? A scab forms. Now, that scab, if you keep irritating that area, will get larger and larger. That's going to narrow the lumen or change the anatomy. And that's what's happening here. Now, we can go in there endoscopically and open that structure up. We can break it up. But the longer you wait, the harder it is to break that up and the more symptomatic you will be.
Yeah, and we just did this episode prior to speaking with you with the patient Samantha, and she goes through her journey and what happened to her esophagus. And it was literally that big. She shows us an allergy pill that she was taking, and that pill got stuck in her esophagus. It was mind blowing.
Yeah. Yeah. And it's because it's subtle symptoms. We evolve, we adapt, and then, but that opening is getting smaller and smaller. It's more and more scarring, stricturing, narrowing.
So, for those people that may be listening and maybe they have a loved one or maybe themselves, what can they expect during an evaluation? Like, what is an endoscopy and why are they so important? Not only for diagnosis, but as we get into the treatment, why that's so important.
Yeah. So an upper endoscopy is a test where we use a small camera to look at your esophagus in this case, right? Not only are we looking, we have the ability during the endoscopy to take samples of your esophagus. And looking is important, samples are important, but we also have the ability during the endoscopy of, remember we're talking about narrowing, opening that narrowing up, or what we call dilation of a stricture. So not only can it be diagnostic, it can also be therapeutic in endoscopy. The reason sampling is so important is that helps us most objectively determine how much eosinophilic inflammation is, or very simply, how many of these eosinophilic cells, these eosinophils have come to rescue or part of this allergic inflammatory cascade.
So, if a patient is on medication and they feel better, they may say, I don't need an endoscopy. But why isn't that true?
So you really want to, any patient that they're better, great. I'm glad you're better. But you want as an endoscopist and as a patient, want to show that you're in remission, which means that not only have you improved the condition, you want to try to more definitively change the trajectory of disease. So the difference is a band-aid medication versus something that's going to change your overall outcome in terms of future stricturing or future symptoms. One of the important functions of endoscopy, even after you're feeling better, is to show how much you're truly responding to the medication. Because there's a few different types of medications, and you want to know, is the medication you're on currently just controlling the flare or reducing the symptoms and reducing the inflammation? In which, in my case, is that more of a band-aid, or is the medication you're on changing the trajectory of disease? Are you changing the amount of inflammation? And that's going to help you determine in the future how symptomatic you will be.
Once a patient is diagnosed with EoE, what are the treatment options that you would discuss with them? Is it dietary? Are there over-the-counter medications? Are there prescription products? Like what do we have choices of?
Yeah, we're more fortunate in 2026 than we were in 2022, or even 22 is probably
Yeah.
the kind of the tipping point. So it's all of the above, right? So when I make a diagnosis of eosinophilic esophagitis, we then have our patient work together with a dietitian and an allergist. All right. Alongside that plan, we also start talking about medications. Okay. The dietitian allergist route is effective, but it does require quite a bit of buy-in from everybody. And the reason for the buy-in is often to do a true elimination diet, you have to eliminate a category of food and then redo the endoscopy. Because, we talked about you need to go back and say, hey, is this really changing the inflammatory cascade? We now have fewer eosinophils. So it is not a one-stop, you get and for allergy testing and you're done, you're good for EoE. You really have to go and commit to a longitudinal process, okay? But it works. So we have all our patients with eosinophilic esophagitis work with a dietitian, or at least be offered a dietary consultation. Same with allergist, all right? If we're beyond the elimination diet for a variety of reasons that we either can't do it or it's not effective, then we start talking about medications. And there are over-the-counter acid suppressors that are often tried first. Though in my experience, those are of a lower dosage than what's indicated or really effective. So I prefer a prescription strength acid suppressor as then the first line prescription option. Okay. And there are a cohort of patients with eosinophilic esophagitis that will respond to a proton pump inhibitor like a Nexium or a Prilosec or esomeprazole of the world. And those patients, if you do respond, you want to go back in and show, is this response going to be more definitive or is it transient? Once you're beyond those, we now are fortunate, again, in 2026, that we have more what we call disease modulator therapies. We can really change the inflammatory cascade as opposed to just changing our symptomatic relief. The one that, that we commonly use, and it is for those patients who are not responding to a proton pump inhibitor, there's really two classes of medication in that category right now, right? There's Dupixent, and then there is oral steroids or budesonide. More recently, there is a more, I want to say, specific mechanism or specific drug just that we don't need to compound, which is called EoHelia. So again, we're very lucky in 2026 because we have multiple choices.
And what are the differences and in those two? Is one an injection and the other one's a steroid, inhale, an oral?
Yeah, so Dupixent is an injection, where EoHelia is basically, I call it similar like liquid IV that you can drink. You make a little slurry for yourself. So there are risks and benefits and ease of use and not ease of use for the different options there.
So the take-home message is there are options beyond dietary interventions that patients can discuss with their healthcare providers to find the best option for them, because there is no one size fits all. What works for Sally may not work for Mark.
100%. That is the easiest take-home message.
Beautiful. Now, as we wind down this episode, I know you're busy, you have to get back to your patients, but what do you think are the final takeaways for patients, or actually they may not even be patients yet, for our listeners? What should they remember from this conversation?
If you're having persistent swallowing issues, if you're getting afraid to go out to eat because things may get caught up and you're mindful of that, if you're thinking twice about it, talk to somebody about it. Start with your primary care provider. If you already have a gastroenterology provider, speak with them, because there is a possibility, a real possibility, that this isn't normal, even though you've adapted to make it normal for you. You've normalized it, but it doesn't have to be that way.
Thank you so much. And if patients want to follow you, you are the Gut Doctor podcast, and they can get that on Apple and the other podcast platforms.
They sure can. Yeah, I appreciate that.
Beautiful. And we thank you so much for joining us today. Listeners, if you or someone you love experiences ongoing swallowing difficulties, food getting stuck, or unexplained chest discomfort, don't ignore the signs. Eosinophilic esophagitis is a manageable condition, but recognition is the first step. This podcast is available on all your favorite podcasting platforms, as well as on YouTube, where you're watching it now. Please like, subscribe, and share. There may be someone who needs to hear this information. And also, don't forget, if you need more answers, evidence-based information, download the Ask Gastro Girl app. It's your guide and your trusted guide for digestive health, education, and information. Thank you so much for joining us today.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.